Basically, S antigen seroclearance is regarded as a realistic goal in the management of patients with a chronic Hep B. This S antigen clearance is called functional cure. The reason why we are pursuing this S antigen loss is that once S antigen loss is achieved, we can expect better long-term outcomes, including development of HCC. However, main barriers for achieving this functional cure is that there are many reservoirs for Hep B replication and S antigen production. It could be from cccDNA in the hepatocyte, or it could be from integrated HBV DNA in host cells. In addition, patients with Hep B infection usually have impaired immune response against the Hep B virus. The problem is that S antigen loss occurs very rarely in the natural history of Hep B infection. We've been treating with various antiviral treatment to achieve this goal. However, the rate of this S antigen loss is very, very low with the current antiviral treatment, such as interferon or oral antiviral treatment. Recently, some studies show that if nuke is stopped, and it might increase the chance of S antigen loss by host's immunity. However, this nuke stopping strategy did not work well in Asian patients. And this stopping strategy always carried the risk of hepatic decompensation, which sometimes can be very dangerous to patients. Regarding the way of S antigen seroclearance, we have many targets for this functional cure, considering the natural cycle of Hep B infection. Drugs on the pipeline these days try to block these targets. Some drugs, for example, anti-CP inhibitor does not allow HBV enter into hepatocyte, and some drugs block translation of viral RNA, and some drug will block capsid assembly. There is also a drug that reduces the secretion of S antigen into the bloodstream. So these are the potential therapeutic targets for achieving functional cure in patients with chronic Hep B. Unfortunately, there has been no strong indicator to guarantee or predict S antigen seroclearance so far. However, some studies reported that when we measure S antigen titer in the blood, this may reflect the possibility of S antigen seroclearance in the natural history and in patients under antiviral treatment. The lower S antigen titer, the higher probability of S antigen seroclearance. And for your second question, last year we compared the long-term outcomes between spontaneous S antigen loss and treatment-induced S antigen loss. And actually, this study was published in Hepatology last year. The conclusion of our study was that no significant difference in the long-term prognosis, including HCC, death, and liver transplantation between these two S antigen loss. In other words, once S antigen loss is achieved, regardless of the way, and we can expect a good prognosis. And therefore, the way is not important based on our study. And following study from Hong Kong also showed a consistent result with ours. In conclusion, most important thing is, again, how can we achieve this S antigen loss, and how can we increase the rate of S antigen loss, regardless of the way? In general, when we look at the risk of recurrence after liver resection, the risk is the highest shortly after the liver resection, and then it goes slowly down up to about 2 years. Then the risk begins to increase gradually from that point. And unfortunately, the risk of recurrence is never going to be disappeared. Based on these fact, and recurrence after liver resection can be divided into early and late recurrence, depending on the timing of recurrence. When the recurrence occurs within 2 years, and this is usually regarded as early recurrence, this early recurrence is mostly originated from residual tumor in the unresected liver, and this is basically associated with aggressive tumor biology. For example, large size of tumor, multiple tumors, or tumors with vascular invasion. However, when the recurrence occurs after 2 years, then it is called late recurrence. This late recurrence is considered a newly developed tumor, even though it is still referred as recurrence. But I would like to say this might be technically new tumor. So therefore, risk factors for late recurrence share with conventional HCC risk factors, for example, male, old age, and uncontrolled underlying liver disease. So the study we presented in this AASLD 2021, we focused on late recurrence rather than early recurrence, because as I mentioned earlier, we would like to know whether there is a beneficial effect of S-antigen seroclearance in the risk of HCC recurrence after liver resection. So interestingly, the result of our study showed that S-antigen loss was associated with a lower risk of HCC recurrence. The point I would like to stress out from our study is that first, even after receiving liver resection for HCC, there is still beneficial effect of S-antigen loss, which is reducing the recurrence. And second, you might remember a few years ago, there was a debate regarding whether SVR in Hep C virus affects the risk of HCC recurrence. And many studies concluded the risk of recurrence was not associated with the SVR achievement. And our study is under similar context. Only topic was changed to Hep B instead of Hep C virus. So I would like to say, even after HCC diagnosis, once patient received curative treatment, they can still be the candidate for HBV cure, because as will be shown in our study, S-antigen loss will reduce the risk of HCC recurrence. There's been lots of effort to improve the rate of S-antigen seroclearance for the past decades. With existing treatment, which is a nuke or interferon, we are not satisfied with these options to increase the rate of functional cure, because the rate of S-antigen loss by these two treatments are still very low, especially in Asian patients. However, there are lots of new drugs on the pipeline for functional cure of HBV. New treatments on the pipeline work on various ways of HBV life cycles, and some new treatment try to enhance our immunity to clear this virus up. Promising early phase studies have been reported recently. However, we still have to wait more studies because many questions are still unanswered. For example, which class of drug will be mostly effective for functional cure? It could be siRNA, or it could be CPAM, or it could be other types of class. In addition, we have no answers whether just one class of drug is enough or a combination of drugs are more effective to achieve functional cure. I think together with this new treatment, the role of existing treatment should also be studied. Nuke or interferon, are they still needed for functional cure, or what combination will more work? I think these questions should be further studied in the near future.